We're very, very pleased that Naveen Bangia, who is the representative from the binding site, is able to be here today and is going to go forward right now and talk about understanding the lab testing for myeloma, and particularly about the role of free light and heavy light testing. So please welcome Naveen to talk about the lab testing.
That's fine. Thank you. All right. So I apologize I couldn't make it here yesterday. I was in the UK for a meeting, so but I was able to make it today, and thanks again to the IMF for inviting me. So as Dr. Jury said, I'm Naveen Bangia. I'm a scientist, work at the binding site, where we are a specialist protein company. And we make blood testing for proteins in your blood, and we specifically focus on myeloma. And so one of the main tests that we make is the free light test. So what I wanted to touch on today was what is myeloma? You've heard a lot about that, and you're probably very familiar as well. Why do we test, and how do we test when looking for myeloma? So myeloma is also called a monoclonal gammopathy, and if you break down that word, it simply means, mono means single, so it's one type of cell, it's a clone of cell, so it's a single type, and it's a gammopathy, which comes from the word gamma globulin, and that is synonymous, so it's a synonym for immunoglobulin and antibody. So we use these words interchangeably when we talk about myeloma. Gamma globulin, immunoglobulin, antibody. So just keep that in mind. I'll try to point that out as we go along. So it's one of a class of diseases called monoclonal gammopathies, and they're shown here. This is of some 46,000 patients that were seen at the Mayo Clinic over 40 years or so. And what you can see is that of these classes of diseases, the largest one is this MGUS, or monoclonal gammopathy of undetermined significance. And all that big mouthful means is that in your blood you have too much of one type of protein, but there's no other problems with your organs or anything. So that's 57%. Myeloma here is about 18% of these diseases. Amyloidosis is 9.5% of these patients, and they're smoldering at 4%. And the big concern with MGUS is that there's a small chance, there's 1% chance every year that you'll actually become a myeloma patient. So every year you have a 1 in 100 chance of becoming myeloma. So I was kind of confused as a scientist thinking, it's a monoclonal gammopathy, mono means single, and it's multiple myeloma, multiple meaning many. So I didn't understand that mono versus multiple. And when I look back at the history of it, it started to make sense. So the name comes from, obviously multiple means many, but the Greek term myelos, which means marrow. And so really it means many marrow tumors. And if you think about if you read a little, and I read a little bit about the history of it, and this comes from the first described example of myeloma, and that was Sarah Newberry in London, England in 1844. And so for 4 years she had severe back pain and bone pain, and had to be carried from her living room to her bedroom by her husband. And when she finally passed away, and they did an autopsy, they found that portions of her sternum, so in her rib cage, it was replaced by this red pulpy substance. So it wasn't solid and hard, it was red and soft and mushy. And that was also seen about 30 years later by Dr. von Rusitsky in looking at a patient in Russia. Dr. Otto Koller saw this, and in Russia sometimes it's still called Koller's disease. And so it's really about many tumors in the bone marrow. So we know now a lot more about myeloma, that it's a disease of one of your immune cells called the plasma cells. And you can see on the left here the blood flow. You've got red blood cells that are carrying your oxygen around, and those little purple things here are white blood cells. So they're just purple because that's the stain, the color that we can put on them in the lab. So your blood circulates your red blood cells and white blood cells all around your body. The white blood cells are important in fighting off infection. And so they go around the body, and here's some of your white blood cells, your T cells, macrophages, B cells, and I'm gonna focus today on the B cells, which are what become plasma cells, and then those plasma cells are what make antibodies. So remember that the bone marrow, our bone marrow is an amazing place when you think about it. It's actually where all these blood cells start developing. They all start in our bone marrow. We have all our different white blood cells. They're all shown here, basophils, monocytes, T cells, all doing something important to help fight off infection. That's what our white blood cells are all about. They're our immune system. And our red blood cells are also developing in our bone marrow. And the challenge in myeloma is that you've got too much growth of this one type of plasma cell that it crowds out some of these other cells that are trying to develop normally. So if it's crowding out your red blood cells, they carry oxygen, and now your red blood cells can't be formed properly in their bone marrow before they go out in the blood, then you don't have as many red blood cells, and then you can't carry oxygen to your tissues as much, which means you're tired. So one of the common symptoms of myeloma is you're tired, or you have low hemoglobin. Remember, your red blood cells are where your hemoglobin is. The other part is that there's all these different white blood cells that are being formed in your bone marrow. So if the myeloma is crowding out all these other white blood cells from forming, those white blood cells are supposed to help fight off infection. If they can't form correctly, then you have a hard time fighting off infection. So another one of the symptoms of myeloma is that recurrent infections. So I want to first talk about how the B cell works in our normal immune response and the plasma cells, and then I'll talk a little bit about myeloma and the lab testing. So a B cell, we've got millions of these in our blood. Each one is different because each one on the surface of it has this little antibody that's got a certain a fit for a bacteria or a particular piece of a virus. So each of our B cells is different. They have a slightly different antibody on their surface. And their job is to survey our whole body and find out, do we have anything that fits this? Do we have a bacteria or a virus that fits my little receptor? And if it does, then that B cell gets all activated. It turns into a plasma cell. And since this antibody at the surface was the right type of antibody to fight off that, or to recognize that bacteria, then we want to make lots and lots of it. And that's the job of the plasma cell. Make lots and lots of that one type of antibody because it fits with that bacteria and it'll help fight it off. And it'll go out and neutralize it. The plasma cell doesn't have the antibody stuck on its surface anymore. It just spills it out into circulation. So you get lots of replication, so you get lots of these plasma cells being made and a huge amount of antibody production. And you can imagine that if you have a bacteria, you're not just going to have one plasma cell doing this. You'll have 2, 3, 4, 5. You have 10 or 15 of those different antibodies being made to fight off that infection. So when you have an infection, you have lots of different plasma cells being made, and they produce antibody to fight off this little bacteria. After the infection's gone, we don't need those plasma cells anymore. So many of them die off, and that makes sense. So the immune system is this constant expansion and contraction. So we make lots of plasma cells for fighting off infection, and then many of them die off. In myeloma, the problem is there's too many of one type of plasma cell. And so each myeloma cell then release one type of antibody. Remember, antibody is the same as gamma globulin, and that's why it's called a monoclonal gammopathy. So one clone, one type of cell, making this gamma globulin. So what are plasma cells exactly? What are they making? Here's a plasma cell. Here's its nucleus. And this Y-shaped molecule is the antibody. That's the antibody or immunoglobulin. You can see it's got 2 heavy chains. They're just the larger chains. They're in black. And 2 light chains, the 2 green. And they are all bound together to make one antibody protein, or immunoglobulin protein. Now, in the process of making these 4 put together, the plasma cell sometimes releases some light chains that are not bound up to the heavy chains. Those are what's called free light chains, and that's what the test is measuring. They're free, not because they don't cost anything. They're free because they're not bound to the heavy chains, okay? So this is what we call an intact or whole antibody or intact immunoglobulin. Now, a plasma cell can make this type of heavy chain and this type of light chain, or it can make the heavy chain combined with a different type of light chain called lambda. So throughout the rest of my presentation, we've got green is kappa light chains and pink are lambda light chains. And you can see lambda here can also be produced by the plasma cells in a free form. So we've got many types of antibodies in our blood to help fight off infection, and they're each a little bit different. Reminder, antibody is the same as immunoglobulin, and immunoglobulin abbreviation is this capital I, little g. And you'll all know about this because you'll know your IgG kappa, your IgG lambda. What that tells you about is it's abbreviation capital I, little g, and it'll tell you about what type of heavy chain you are and what type of light chain. So I'm going to show you that here. You can see the black heavy chains are, in this case, G, and the light chains, remember they're green, that means they're kappa. If they're pink, they're lambda. We have other antibodies in our blood, other plasma cells that make IgA, and you can see I just changed the color of the heavy chain. So the pale blue is an A heavy chain combined with kappa. And so somebody yell out what this molecule is. IgA lambda, excellent. And then we've got IgM kappa, so what's the next one gonna be? Awesome, you're all still awake, good. So the reminder here is that when you're looking at your lab results and you're thinking about what type of myeloma you are, the capital I little g just means immunoglobulin. The next is the heavy chain, and then the next is the light chain. It just tells you heavy chain is combined with which light chain. That's what your plasma cells, your myeloma cells are actually making. And that tells you how many, by measuring this in the blood, as Dr. Dury said, by measuring it in the blood, it tells us about how many myeloma cells are actually in the bone marrow. So it's to avoid going into your bone marrow every week to look for how many plasma cells, how many myeloma cells there are. You can just look in the blood for how much immunoglobulin or free light chains there are. Now, each myeloma patient is different, and if these are your myeloma cells, they can be releasing the intact antibodies shown here in this Y-shaped molecule with a lambda light chain, and in addition, they can release the light chains only. So this is what's called intact Ig myeloma. That's about 80% of you out there. 90% of patients also release the free light chains. Some patients don't secrete any of the intact antibody, but they're only releasing the free light chains. So then for these type of people, it's really important to be using the free light chain assay to measure. And then there's a small percentage that your myeloma cells here are releasing very little, if anything. So they're really hard to detect in your blood what is the antibody that's being produced or what the proteins that are being produced. So why do we test? A lot of questions come to mind when you're diagnosed with myeloma. And looking at your lab tests, there's a lot of questions that are probably going to be concerning you. How bad is it? How far along? What stage? And when you think about the lab results, they can be grouped into two buckets. They're trying to answer the question, how many myeloma cells are there in the bone marrow? And the other question is, how bad is it damaging the organs? So that's the bottom line. You can take all your tests and put them into one of those two buckets. So in looking at the question, the bucket of how many myeloma cells are there in the bone marrow, the gold standard is this unfortunate technique, where a big old needle goes in and they pull out some of the bone marrow cells, and they ask how many of those cells in the bone marrow. Remember, the bone marrow has all those different types of cells developing? That's how I started this presentation. It's got all the different white blood cells. It's got red blood cells developing. Well, there should be a good mix. But if there's too many plasma cells, that's a problem. That's that's an evidence of myeloma. So the other test in looking at how many, or trying to figure out how many myeloma cells there are in the bone marrow is by testing the stuff that they release, the antibodies or the immunoglobulins or the free light chains. So when you're measuring the kappa light chains, you're measuring in the blood, you're measuring how many myeloma cells approximately are there in the bone marrow. When you're thinking about your lab results, there's some really important practical points that I want to bring up, and that is always look at the reference range. It's usually in brackets in your lab report, so are you above or below it? And try to group the results and look at them together. So the results that are looking at your protein that's being released by your myeloma cells, that would be your M spike. Look at that together with your free light chains and see if they're both making sense going in the same direction. And that comes up with this point is see if you can graph it and see if you can see a trend that's going up or if it's going down. And does that trend make sense with your symptoms? Are you feeling better and the numbers are going down? That's, try to put all that together. And ask questions, ask a lot of questions, especially of these three guys when they come up the panel in a few minutes. So myeloma is, if this is your bone marrow with lots of different types of plasma cells, each one making a different type of antibody, myeloma is the growth of one type of plasma cell making one type of antibody. So how is it diagnosed? It's the blood testing that's done. It starts there with a prick in your arm, and it's not as easy as something like this. Diagnosing myeloma is quite a challenge, but the blood's taken back into the lab, And a small amount of it is put into this agarose gel, which is basically Jell-O. So imagine Jell-O that you make at home in a little slab and a little hole punched out to allow a drop of blood to go in there. And then we separate the proteins out based on their charge. We apply an electric current across these proteins. So this is your gel matrix, you know, that Jell-O. And these red, yellow, and green balls are your proteins. You have lots of different proteins in your blood. And we try to separate them out by using an electric current. And that's why it's electrophoresis. So serum protein electrophoresis. The electrophoresis is this part, the electric current applied across, and you can see the proteins separate out. So the ones that are the more negative proteins are attractive to the positive side of the anode, and the more positive proteins are here, attracted to the negative side. So proteins get separated out, and then what we do is we stain them with a dye that binds to all proteins. And this is a red dye that's here, and you can see here's albumin, and then we have a computer program that will go in and ask, how red is this? How dark is that color? And you can see it goes up, and albumin's a very abundant protein. Then we've got the alpha 1, alpha 2, beta, gamma regions, very creative naming by scientists back in the 1800s. But the gamma region, remember gamma globulin, monoclonal gammopathy? Myeloma is a monoclonal gammopathy because it's this region, the gamma globulin region, is where the antibodies are. That's where they're a broad hump. Why are they a broad hump? You can see they're kind of diffuse, kind of across quite a space on the gel. It's because each one is different. So each one has a slightly different charge. And that's why they kind of spread out like this. What happens in myeloma is you take this, and this is the same serum protein electrophoresis, but stained with a black dye, albumin. There's your gamma region. It's kind of diffuse, and it's kind of spread out. And gray, well, in myeloma, you've got one protein, lots of it. And what happens then when you have one protein and lots of it is a very dense, very dark band. And you can see this, what's called the M spike. And the way that this is quantified is the computer calculates the area underneath that curve. And so that's why it's called an M spike, for a monoclonal spike that's seen on this pattern. So protein electrophoresis has been around since the 1800s. The free light test was developed in 2001, and it measures something much more specific, and it allows us to detect, if you're detecting free light chains, you can detect all three classes of these types of patients. When you're just measuring the intact protein, you're not able to detect everything. So this I already mentioned, it detects, the free light chain test detects the free light chains, not the one that's bound up. It can be used at diagnosis, especially the guidelines recommend serum protein electrophoresis together with free light chains. During response to treatment, so is your treatment working? The numbers should be going down. The normal ranges for free light chains are between 3 and 19 for milligrams per liter for kappa and 5 and 26 for lambda. And we all have free light chains. Every healthy person has free light chains floating around in their serum because we have plasma cells that are there to fight off infection. So when you think about the ratio that we get from this, the kappa to lambda ratio, we have a normal range, and that's shown here between 0.26 and 1.65. Since kappa is in the numerator, if a myeloma patient has lots of kappa, then they're going to be in the ratio will be in the hundreds to 1,000s and so on. If they're a lambda, then that's the denominator is very high, then they're going to have decimals. And in either case, during treatment, you want to see movement back towards normal. So I just want to go through a few free light chain results so you can kind of see what I mean in terms of interpreting. This is a patient that comes in with fatigue. Their free light chain results for kappa and lambda are 15 and 24. 15 is within the 3 to 19, so it's normal. So that's why it's green. 24 is within the normal range for lambda, and the ratio is normal. But then when you combine it with other lab tests, there's no other monoclonal protein seen on serum protein electrophoresis, so it's probably not a myeloma. So the next one, I want you guys to shout it out. So is kappa low, medium, or low, normal, or high? Awesome. And so this is a, what do you think? Normal for lambda, and the ratio is? Perfect. So it looks like there's monoclonal kappa light chains in this case. And in this case, yell it out for kappa. Low, okay. Lambda? High, and the ratio is low. So you've got a lambda producing clone here. It's probably causing some suppression of the kappa. So you've got a monoclonal protein. this is just an example of treatment, and you can see how if you look at the free light chains and over time during different treatment and how you can watch it drop all the way back into the normal range. And that's helpful for monitoring disease. Last few points. When you see changes in your lab results, be really careful that even a stable patient, a patient with stable myeloma, the M spike or the free light chains can fluctuate by about 20 to 30%. So if you're 100 and you get a result of 80, don't get too excited until you see the next result. So you want to see at least 2 points dropping in the same direction or going up if you get concerned. If you see some big differences, if you're coming down to Florida in the winter and you're getting your lab testing down here compared to, you live up north, there might be differences. So be careful in interpreting that. Make sure you get the same sample run to both places if you're going to do that. So I really want to just summarize by mentioning, I talked about monoclonal gammopathies. Remember that gamma globulin, immunoglobulin, and antibody are the same thing. Myeloma is too much of one type of plasma cell. And detecting with the free light chain test is a really sensitive way of being able to monitor your disease going up and down. But be careful, the 20 to 30%, make sure you see at least twice that result is going in the same direction. If you need more information, you always feel free to reach out to Binding Site. On our website as well, we've got some webinars and such, the educational things for monoclonal gammopathies down here. And with that, I'd like to thank you and take any questions. And this here is a farm in Vermont where it all starts. The free light test starts with immunizing sheep to detect patients' free light chains.
Yeah, they use sheep. So you can stay. I haven't seen all of our panel members, but if you're here, would you please come up and we'll take questions for the first couple of talks, actually. Why don't we just stay right here?
Okay.
Yeah. I see Dr. Cole is headed up here now, and behind him is Dr. Phil McCarthy, and then behind him, Dr. Rafat Abanar. So please welcome our guest speakers for today. That's great. So your first test is to identify your name.
Good morning. How are you?
Yeah. Okay, so questions about...
Right over here, doctor.
Go ahead.
Hi, Dr. Dury. You mentioned this morning, of course, the need for PET CTs with respect to identifying whether the cancer is spread within the body. And yesterday, the Nurse Leadership Board person said, do not ever have contrast media for a PET CT because of the danger to the kidneys. And now I'm wondering, okay, what are we supposed to do?
Oh, okay. So for the PET, the agent that's given is it's a sugar. It's a type of radioactive sugar, and so that is not damaging to the kidneys. So that's different. Now, we sometimes use a contrast to enhance CT or MRI, and that is what is not recommended in myeloma. But giving the sugar is something which is not harmful, all right? Yeah.
Great. Thank you. Right over here.
The
Yes.
difference between the M-spike test and the free light chain test, can you have no M-spike at all and just present in free light chain?
Yeah, so that's exactly that case of free light chain only myeloma. So the M-spike test is also not very sensitive. So it'll drop to be negative or that it's normal, but there might still be some free light chains, and so you can still see detectable light chains that are above normal.
Right. An additional part of that is that maybe 30% of patients who have like an IgG kappa, in addition, they'll have the free kappa. They'll have extra light chains.
Right. During your presentation, I believe you said that everybody's got kappa-free light chains. The key to it is keeping normal. The key to it is it's okay if it's in the normal range. I've had several instances when I was in complete remission with kappa-free light chains that were undetectable, which means we're close to zero. Is that an anomaly, or is that the typical?
That is unusual. So that range of 3 to 19 is 95% of people. So to be below that and are completely undetectable.
In fact,
You know, sometimes what happens is that if you are on continuous treatment and you're suppressing your immunoglobulin productions, may actually have lower light chains, intact light chains. So it's not an unusual, we see that periodically.
Yeah, particularly, for example, on Revlimid maintenance, for example, sometimes the kappa level will drop very low, and when you stop it, you'll find that that kappa level will go back up again a bit.
Please elaborate a little bit about non-secretory myeloma, how you monitorize that evolution of the disease and non-secretory myeloma.
Non-secretory.
And there is a diagnostic of non-secretory myeloma.
Sure.
There is some importance on detection of the intracellular
Sure.
globulins.
So someone want to comment on that? This is a tricky area.
Yeah, in the old days, it used to incorporate a lot of patients who had serum-free light chain abnormalities because we were focusing on the SPEPs. So now we're capturing more of them, so they're no longer really non-secretory. And there were also some who are IgD myelomas, which would get missed because it wasn't tested for. So excluding all of those, if you have a true non-secretory, the best test, unfortunately, is the bone marrow test with regards to making sure that you do not have disease progression or imaging, but that's usually with symptoms, such as a PET CT or the MRI. So you can do intracellular testing for immunoglobulins within the marrow, but you have to have a marrow anyway. So if you're having plasma cells looked at, you can look at the presence or absence of clonal proteins within the cell. But it becomes very difficult. You have to look at indirect things. Unfortunately, if you have truly no serum-free light chains, no IgD, nothing on the SPEP or immunoelectrophoresis.
Right. The one thing I'd emphasize, though, is that the status of non-secretory is something that can happen later in the disease, so that if you've had myeloma for a lot of years and we're monitoring, we do need to be careful about monitoring, like for non-secretory relapse, where we need to be alert that even although the protein might be low or even absent, we need to be checking with imaging and keeping a close eye to make sure that there's not some active disease.
And the opposite is correct.
Yes.
You know, you can be non-secretory and you start producing a light chain. So
Yes.
I think following the free light chain periodically could become a new marker of the disease.
Exactly. Okay,
right back
we have time
here.
for one or two more questions. Yeah.
Right here?
I want to see if I understood this correctly when Dr. Dury spoke earlier.
Okay.
Regarding, I am not a fan of a bone marrow biopsy, and it seemed.
Bone marrow biopsy.
But you seem to indicate that we could receive enough information from getting complete blood chemistry and that bone marrow biopsies are not necessary. Did I interpret that correctly?
Well, possibly. I mean, I think that obviously at the time of diagnosis, we always have to do the bone marrow. But after diagnosis, we try as much as possible to make our conclusions and decisions based upon the changes in the blood. And so that's what I was trying to show you. For example, we now know that there are myeloma cells in the blood. And so if the myeloma is active, we could possibly pick up active myeloma using a blood test versus the bone marrow. And so we're looking towards that for the future to try to not be so dependent on doing multiple bone marrows.
But in order,
Yeah.
when patients are diagnosed and sometimes when they relapse, we do need a bone marrow biopsy in order to not only count the number of cells, but also to use the cytogenetic tests, and particularly the FISH test, to especially to ascertain if there's high-risk features to the disease. With the deletion of the 17th chromosome is a high-risk type of myeloma, and the translocation of chromosome 14 to either 16 or 20 are high-risk features that can occur at the time of diagnosis or later on. So getting bone marrow biopsies, unfortunately, has still been part of what we do for myeloma, but what we get out of the bone marrow biopsies today are much greater than what we got out of it in 1844 with Sarah Newberry.
Yeah, I
So
would
not,
add,
it's not quite gone away yet.
and I'd add to that, especially now since there is venetoclax, which hits or targets those myeloma patients, so 11, 14 in particular. And because, as mentioned, myeloma can be have clonal heterogeneity. In other words, you may have an abnormality at diagnosis which goes away, still stays around, or you may have a new one at progression. And in particular, 11, 14 combined, those patients can be treated with bortezomib, dexamethasone, and venetoclax. And this is a new way of salvaging. So I try sometimes, if the biopsy in particular is painful, just do an aspirate, because we can get a lot of information from the aspirate in terms of CD138 selected fish and a variety of other things. So I do think it's going to be more important. As Dr. Dury said, hopefully someday we'll be able to do all of this with blood testing, but unfortunately, since the marrow is the primary scene of the crime, we're still focusing on that at present.
We're stopping. Thank you very much. Thank you, Naveen. Thank you to our panel.